Hello. In this presentation, what I want to do is tell you a bit about the basic theory of CBT and some of its characteristics. This is important because CBT, like any other therapy, is not just a random collection of techniques, but rather is based on a coherent theory, and if you're to make the best use of it, it's important for you to understand that theory. So let's begin with what is perhaps the fundamental idea behind cognitive therapy of any variety. And it's perhaps easiest to explain this by starting from what we might call the common sense model of what makes people feel a particular way. If we ask people what makes them have a particular emotion, then very commonly what people will answer is with some event or situation. Something happens that makes them feel a particular way. In this example, somebody loses a job and they end up feeling sad or depressed. But if we think about it, it's pretty clear that actually things can't be quite that simple, because if they were, then everybody who experienced a particular event would feel the same way. And we know from our ordinary lives that that's not true, that people to varying extents respond differently to the same event. So there must be something else going on. And the basic idea of cognitive therapy is that indeed there is something else going on. What's going on is cognition, the interpretations that people make of events, the meanings they take from the event, their thoughts and beliefs about the event. All of these we call cognitions, and hence we get the idea of cognitive behavior therapy. So let's take a simple example of this. Suppose somebody is fired from their job. Then there are actually a range of possible meanings or thoughts that people may take from this, and therefore a range of emotions. So for example, one might have the thought, how dare they? Perhaps particularly if, for example, if you discovered that the job was going to be given to the boss's son, then you might well have a thought like that, and associated with that would be the emotion of anger. On the other hand, you might have a self-critical thought that I'm a failure, my life is in ruins, in which case you probably would feel sad or depressed about it. On the other hand, you could conceivably have some positive thoughts about it. You might, for example, have been quite fed up with your job and feel that it was time for a change, and this is pushing you into action. So you might have a thought like, this is a chance to start again, in which case you might feel perhaps a bit nervous, but generally positive. So different thoughts, different meanings for the same situation can give a whole range of different emotions. There are some fairly obvious implications of this basic idea. First of all, that it's not events in themselves that matter, but rather the meaning of those events to a particular individual. Therefore, what seems on the surface like the same event can have very different emotional consequences depending on an individual interpretation of that event. And lastly, when an emotional reaction seems out of proportion to an event, as may often happen in clinical settings, then it's the idiosyncratic meaning that the person is taking from that event that explains that emotional reaction. Further implications. To understand people's distress, we need to understand their cognitions, i.e., their individual ways of perceiving the world, the kinds of thoughts and beliefs that they have, the way the world appears to them. We may be able to reduce people's distress by helping them to change those interpretations, and hence we have cognitive behavior therapy, a therapy which aims to help people examine and, if appropriate, modify the thoughts and beliefs that they have about what happens to them. Now, I've talked so far as if cognition were all the same, as if it was just one lump of thoughts and beliefs. But in fact, quite commonly nowadays, we distinguish between different kinds or levels of cognition. So let's just talk a bit about that, and I'll say a little more about each of these in a moment. So the common levels that we distinguish, at the bottom level, or the most general level, we have what are sometimes called core beliefs, or schemas, or schemata, as some people call them. These are very general and basic beliefs, often in very absolute terms, about oneself, about the world, or about other people. So these are beliefs like, I am a bad person, or I'm not very competent. Very general and absolute beliefs like that. At the next level, we have what are called dysfunctional assumptions. These are beliefs that often take the form of rules for living, guides for how we should cope with different situations, and they often seem to be developed as a way for people to cope with their core beliefs. And then at the most obvious, most specific level, we have what we call negative automatic thoughts, NATs, or people sometimes call them NATs. These are specific thoughts that happen in particular situations, and probably most of us are familiar with this kind of the thought. The kind of thought that, for example, if you walk into a party where you don't know anyone, this is the thought at the back of your head saying, nobody's going to want to talk to me, nobody likes me, I'm very boring, and so on. So let's talk a bit more about each of these. First of all, core beliefs. As I mentioned just now, these are generally very absolute statements. I am unlovable, or I'm bad. People are out to hurt you. The world is a dangerous place. And they're generally learned quite early on in life, although sometimes they may develop or change later in life. Most obviously, perhaps in PTSD or other reactions to trauma, where a particular traumatic event later in life may, for example, switch somebody's belief from the world is generally a benign, safe place to the world is a dangerous, hostile place. These kind of beliefs are generally not directly worked with in short-term therapy for common mental health problems like anxiety disorders or depression, although they may shift despite the fact that we don't specifically work with them. They may be more important for so-called personality disorders. At the next level, we have these dysfunctional assumptions. As I said, rules for living, ways for coping with core beliefs. And these are usually conditional. They very often take the form of if such and such, then such and such, or I should or must do this, that, or the other, otherwise something bad will happen. So, for example, if I have a core belief like I'm useless, I may develop a dysfunctional assumption to help me try and cope with that says I can hide my uselessness if I always do everything perfect. So I must do everything perfectly, otherwise my uselessness will be revealed. These are usually not as obvious as negative thoughts and may not be specifically verbalized by a person. We often have to infer them from our actions, from the way people behave. We may develop an idea that they seem to be operating on a particular rule. These are usually tackled later on in treatment. And then at the topmost level, we have these negative automatic thoughts, NATs. A constant stream of thoughts about events, situations, people, and so on. The meaning we're taking from the situations that we're in. Now, these are called automatic because they are automatic. These are not the kind of intentional thoughts that you might have if you're sitting down and trying to focus on something. These kind of thoughts just pop into your head willy-nilly, whether you want them to or not. They usually are, or at least can easily become, conscious. So many people are aware of these thoughts quite naturally, but if they're not, most people can fairly easily learn to become aware of them. So they can become conscious, but they're often initially not noticed. They're so habitual, people spend so much time surrounded by these kind of thoughts that they don't really notice them anymore. Also important is that they're often very plausible. They're taken by the person who's having them as being obviously true. If I have a thought like, I'm making a mess of this, at the time I'm having it, it often seems not like a thought, but like a simple and obvious truth about the world. That's just the way things are. And that's especially so when emotions are strong. Last important point here is that these kind of negative thoughts are not necessarily verbal. I've talked so far about thoughts in the form of, I'm making a mess of this, but it may also be that people have thoughts in the form of negative images rather than words. So rather than thinking, I'm making a mess of this, somebody might, for example, get an image in their mind of themselves looking foolish in some way, perhaps looking red-faced or stuttering or shaking or something like that. These kind of negative thoughts are the main focus of most CBT, certainly CBT that's designed to treat common mental health problems like anxiety and depression. And they're usually tackled early on in therapy and continue to be tackled throughout therapy. Perhaps one other important point to make here is that all of these kind of thoughts and beliefs are not supposed to be unique to clients. All of us have these kind of thoughts and beliefs, negative thoughts, negative dysfunctional assumptions, and so on. And therapists have them just as much as clients do. So an example of these different levels of cognition, perhaps somebody might have as core beliefs things like, I'm unlovable or I am defective in some way. They might then develop dysfunctional assumptions to try and cope with those core beliefs, perhaps something like we have here, that if people get to know me, then they will find out how unlovable and useless I am, so it's best if I take care to not reveal very much about myself. Or I must succeed at everything I do, and if I manage to do that, then I can conceal my fundamental uselessness. And then at the topmost level, we have negative automatic thoughts based on those beliefs. Thoughts like, I don't know what to say, I'm making a mess of this, I'm a failure, she doesn't like me, all kinds of different specific automatic thoughts that may occur in specific situations. So let's look at some of the characteristics of these different types of cognition. So we have these three levels, and they vary along a number of dimensions. First of all, they vary in how specific they are. So at the most general level, we have core beliefs, which are very general, applied to a very wide range of situations. And then at the top level, we have negative automatic thoughts, which are the most specific. They occur in particular situations. Then they vary along the dimension of accessibility, how easy it is for people to become aware of them. So typically, core beliefs are the least accessible kind of thoughts and cognitions, and negative automatic thoughts, as we were saying just now, for most people are relatively easy to get hold of. And then lastly, and of course important for us as therapists, is that core beliefs tend to be the most difficult to change, whereas negative automatic thoughts tend to be relatively easier to change. One other distinction between different kinds of thoughts is that there tends to be typical content of negative thoughts in different disorders. So, for example, in depression, Tim Beck, the founder of cognitive therapy, described what he called the cognitive triad in depression. Excessively negative views of oneself, of the world in general, and of the future. So, putting it crudely, somebody who's depressed tends to think that they are terrible, that the world is a terrible place, and furthermore, that it's always going to be like that. In anxiety, the typical content of thoughts is about overestimating threat in particular areas, depending on the disorder we're talking about. So, for example, in panic, the typical thoughts in panic are about misinterpreting often anxiety symptoms as indicating that something terrible is about to happen. I'm about to have a heart attack, or I'm about to go mad, or something like that. In social anxiety, typically these thoughts tend to be worries about being negatively evaluated in some way by other people. They're going to think I am boring or stupid or peculiar or whatever it may be. In obsessive compulsive disorder, the thoughts tend to be about responsibility for and the need to try and prevent harm coming to oneself or to other people. And so on for other disorders. So putting together what we've talked about so far, we can try and put together a basic CBT model of how problems develop and what the processes are that are involved in psychological problems. So first of all, as we said, typically from early experience, we develop particular assumptions and beliefs, which may go along without causing any major problems for a long time. Often we find ways of living with our negative beliefs, and we may function quite well despite them. But if we come into contact with what's sometimes called a critical incident or a precipitating event, then something happens which tips us into the development of a problem. And we very commonly nowadays describe problems in terms of the 4 systems. So what we mean by this is 4 different aspects of the problem that it's useful to look at because the relationships between them often help us to understand what's going on in a problem. So these 4 systems include cognition, thoughts, beliefs, interpretations, meanings. They include affect, mood, emotion. Physiology, the biological changes in our bodily states. And behavior, observable things that we say or do. And the arrows linking all these up are simply supposed to illustrate the fact that all of these systems influence each other. There are complex relationships between them, so that thought affects emotion, for example. Emotion may bring physiological changes. Behavior may affect thoughts, and so on and so forth. They're all interrelated. So this 4-system model, when it's drawn out like this, is sometimes called, after a couple of cognitive therapists called Podesky and Greenberger, is sometimes called the hot cross bun model because it looks a bit like a hot cross bun. So we have these 4 systems within the person interacting and producing a problem, and of course all of those systems also the person interacts with their environment, which may also influence the problem. And environment here should be understood in the widest possible sense, not just the obvious physical environment, but also, for example, the family environment, the social environment, cultural, economic environment, and so on. All of these things may influence a problem. So to understand people's problems within the CBT model, we need to model these kind of interactions. For our purposes, diagnosis, although it may be very useful sometimes, it's not enough because the same diagnostic label may conceal quite idiosyncratic processes and relationships between these systems. So for doing CBT, we need to have some kind of model of the systems and their interactions. The fundamental principles, the C and the B in CBT, first of all the C, the cognitive principle, that it's interpretations of events, not events themselves, that are crucial, and the basic behavioral principle that essentially changing what you do is often a very powerful way of changing other systems. This is the main legacy that CBT has taken from the previous generation of behavior therapy. that looking at what people actually do can be very important. So, for example, it may be very useful to discuss with someone the likelihood, for example, of their fainting if they go to a supermarket. But although that may be very useful, it's likely to be even more useful to actually go to a supermarket and try it out in real life and see what really happens. The therapeutic approach in CBT is fundamentally a collaborative project. Collaboration is one of the watchwords of CBT, and what we mean by this is that we try as far as possible to have the therapist and the client being equal partners in the project of therapy. The idea is that both are expert in their own way. The client is the world authority on his or her own problems. The therapist hopefully has some expertise in possible ways of trying to manage those problems using CBT strategies, and the two come together to try and bring both their skills to bear on solving the client's problems. So as part of this collaborative approach, CBT tends to be a very open approach to therapy. Knowledge is shared between therapist and client, goals are shared, etc. There is sometimes a caricature that CBT doesn't care about the therapeutic relationship. This is absolutely not true. CBT needs a sound therapeutic relationship just as much as any other therapy does. The only difference between CBT and some other forms of therapy is that in CBT we don't see the therapeutic relationship as being the main tool of change. In CBT we see a good relationship as necessary but not sufficient by itself for therapeutic change. It's the bedrock on which we rest change strategies, but it is not in itself the main change strategy. So all those notorious non-specific factors, therapists being warm, empathic, active, and so on, that have been researched over years, all of these kind of factors are just as important in CBT as they are in anything else. And it's particularly important because, as we'll see in a moment, a large part of CBT is based on asking patients questions. And of course, it's very important, if one's questioning people, that those questions are based on a genuine curiosity about wanting to know the way the world looks to someone. Another important characteristic of CBT is that it uses a broadly scientific approach. What we mean by that is that we try and adopt a stance a little similar to the one a scientist would take towards a theory. So the client's thoughts and beliefs in this approach, one of the things we often say is that thoughts and beliefs are opinions, not facts. What we mean by that is that just like a scientific theory, the client's thoughts and beliefs might be correct, but they also might not be correct. And one of the tasks of therapy is to help clients pay attention to a wider range of evidence that will help to tell them whether their thoughts and beliefs are accurate or whether they're not. The analogy with the scientific process goes even further in that we do also use as a therapeutic strategy something akin to scientific experiments, what are called behavioral experiments. And you can find out more about those in some of our other presentations. As I mentioned just now, one of the keystones of CBT is what's sometimes called Socratic questioning. This is based on ideas of the ancient Greek philosopher Socrates, where it's said that he had a particular distinctive teaching style, that if one of his pupils asked him a question, Socrates would not just give the answer to the pupil, but rather he would ask them a series of questions that would help them to open up their own thinking so that they could arrive at their own answer. And we use this approach a lot in CBT, of asking patients through Socratic questioning to think differently about their thoughts or their beliefs, their ways of interpreting the world, to try and open up alternatives for them to consider. Again, you can find out more about this in a separate presentation on the Socratic method. CBT tends to be very structured. So, for example, an important part of every CBT session is that the first part of every session is spent on setting an explicit agenda with the client of what topics we want to talk about today. This helps us to structure the sessions. It helps us to prioritize and make sure that we're focusing on the most important areas. And it also helps to get our clients involved in what we're doing. Similarly, an important part of CBT is so-called homework, an unfortunate word for some people that has bad associations with school and so on. And it may be important for some people to find a different word. But what we mean by that is that people are expected to work on their problems outside the actual therapy session. So typically the last part of every session is about thinking of something that it would be useful for the client to do, to think about, to try out in the time before the next session. And there is now a little bit of evidence that this kind of homework may be important in terms of outcome. There is some research evidence that people who do more homework tend to get better outcomes in CBT. So, in conclusion, nobody's claiming that this is a brand new idea. Indeed, it goes back as far as Epictetus, a Greek philosopher in the 1st century AD, who famously said that men are disturbed not by things, but by the principles and notions which they form concerning things. We have the basic principle of cognitive therapy there from almost 2,000 years ago. So it's not a new idea, but it has become a very wide-ranging and flexible approach to psychological problems, which we hope you'll find useful.